Dentistry Symposium. Continuing with implant dentistry, the fourth session, presented by Dr. Henriette Lerner, focuses on improving accuracy and predictability in full arch implant protocols through advanced digital tools. Dr. Lerner is an internationally recognized expert in digital implant dentistry. She is a former president of the Digital Dentistry Society International and has extensive experience in clinical research, digital workflows, and complex implant rehabilitation. We invite you to this session that highlights how enhanced digital accuracy and workflow integration can improve outcomes in full arch implant protocols.
So, good afternoon, dear ladies and gentlemen, dear colleagues. It's a pleasure and an honor for me to be invited by Dental Tribune to talk about accuracy and predictability in full arch implant protocols with the smart flags from Apollo. We are all fascinated by digital dentistry, and this is actually the discipline which we are learning and doing every day in our clinics. Having the pretension and expecting from this new discipline based on new parameters to give us a higher accuracy and predictability, and also as a mirroring of the accuracy and predictability and high aesthetic, stability, function, long-term success. Accuracy is the new religion. Since we work with digital technologies, we expect and we need from every technology, but also from the overlapping of the data, of the informations, the highest accuracy possible. Why? Because we expect that the end result is matching one-to-one with the highest accuracy possible with the planned work which we did at the beginning. What is accuracy? Accuracy is the sum of the trueness and precision. So the trueness means the correct value, the precision, the repeated correct value, and the accuracy is the sum of the above. And we expect and we want and we look for the methods, technologies, procedures, and workflows which offer us the highest accuracy possible. In all these cases which we did in the last 10 years of digital dentistry in full arch rehabilitations, we tried to reach the best aesthetic, functional, stability result, and also which is actually the success, the mirroring of the accuracy. So the success, the mirroring of the accuracy is, clinically speaking, a good fit, a good aesthetics, a good function, and therefore a long-term success of the constructions. And we also know from all the studies which have been done is that when we talk about single unit cases on implants, there are very small errors which can be compensated. It is a surgical error, it can be compensated by prosthetics. The technologies have in scanning, for example, or capturing the single unit, not a big chance of error, and if it is some, then it can be compensated. Whereas in full arch rehabilitations, there is an amplification across and a big deviation across the entire arch. So therefore, there is needed a very high attention in the capturing of the data, in the matching of the data, and actually in all the steps of the workflows in full arch rehabilitations, which obviously is much more demanding in order to get to that perfect fit, aesthetic, stability, and so on. When we talk about full arch rehabilitation in an static navigation, we go through these 4 steps of the clinical workflow, which is very well known by assistants, clinicians, technicians, and so on. And we all talk the same language. So that means that when we scan, we capture all the digital data, as we know, beginning with the intraoral scan, with the registration of the movements, with the DICOM data, and so on. We create a virtual patient, which is actually the beginning of the backward planning for us to plan our implants, our bone, our soft tissue regarding and seeing and in harmony with the face. So that means the planning procedure or the plan chapter means a smile plan, so the visualization in 3D manner of the future smile, which is the backward planning for the positioning of the implants, which all has to respect some proportions, which we will see later on. What else do we plan in this chapter? The prosthetics in advance. So we do our digital walks up, which is the beginning of the so actually the image of the provisional, which we apply to these patients as an immediate placement and immediate loading procedure. And of course, we plan a guide, a surgical guide, which will place our implants in the perfect position. Make is the third chapter. That means the printing and the milling. Actually, the printing is the king of the manufacturing right now, and it's still evolving, of the provisional, of the guides, and milling the final. We will see what the future will bring. The done procedure or done stage is the surgery, and each and every surgery, single tooth but also full arch, is guided. So reviewing all these chapters, we have here a case where are ailing teeth in the upper jaw, in the lower jaw too, a couple of them. So we capture the digital data starting with a picture, then x-ray, a 3D information of the soft tissue of the teeth, but also of the bone. So as you can see on the right side, we start to do a smile design. We have an asymmetric situation of the bone and of the soft tissue, which we'll have to compensate through the surgery and try to get to a symmetric result. This is our aim. We're focusing on a FP1 situation in this immediate loading procedures. We tend to get to a as much as possible perfect result. So we start with a virtual patient, as I mentioned before, and we match the cone beam CT, the intraoral scan, the face scan, with help of the AI. So we can match it manually, but use artificial intelligence in all these matchings if possible, and it is possible in many devices, in many software. So take one of those technologies which are able to give you the AI-based matching of this digital data. Then this walks up, which we visualize and the technician made, and be careful that the communication with the technician is really good, because they tend to do a pink component, and we always have to discuss and to communicate with the technician what kind of reconstruction we need to do. So they need to take care of the emergence profile. So it's not an FP2, it's an FP1. So nevertheless, the position of the implants is given by the position of the future teeth. And as you can see here, we keep always 1-2 teeth to support the guide in the vertical position in order not to have a vertical deviation, so to minimize the deviation of the guide, whereas the planning should be very accurate, so the placing of the implants conform the planning. And also we use 3 pins additionally to support the guide and to stabilize the guide in order to have a good and accurate positioning of the implant. So the guide will be designed, and of course we have also registration of the movements of the jaw, which is in this case physiologic, so we don't need to change anything or to crop the movement. We have softwares which are implementable in the exocad planning software. So we use this movement to design the provisional and the contour of the cuspids, the inclination of the cuspids, reproducing a physiologic position and movement. The guide will be designed, as I
Aquí en un
mentioned
seminario,
before,
mira, ven.
in the Exoplan software, and then we go for manufacturing
Se
the
llama-
guide, which is designed, and we have also the perfect positioning of the implants, which we follow then through the guide
Precisión y
surgery. We also
predictibilidad
can
en protocolos de implantes de
judge
arco completo.
and measure
Estoy
the
grabando,
volume
no te pasa.
of the
Sí, me lo
missing
envías. De hecho,
bone,
eso
which we
vengo
have to
con- ¿hay alguien
compensate
viendo, muchachos?
through an
Pero pasa que ya
intraoral
van,
elevation.
llegan
And
como
we
en
go
las 3
straight
y ya
forward
van a
to the
empezar a
surgery.
trabajar.
I don't want to go into
¿Ya
¿Ya
details.
los van a montar
And
o van a hacerlo
here
sobre?
Pues la
we
idea es que
want
vaya vayan
to
montando.
have a provisional which is actually as good as a final, since it's an immediate placement and immediate loading. So what do we know from the literature? We need to do a scan over this immediately placed implants. We note that the scan over single tooth implants and a short span are accurate, but as you can see, and there are many studies underlining that we have an average deviation of more than 50 microns in the full arch scan, and this is not enough to have a perfect fit of the provisional and later on of the final. Of course, we choose from the market the scanners which are showing the highest accuracy. But in order to understand which intraoral scanner and how intraoral scanner work, I would like to share with you that scanners are working differently. So it can be that the scanner have a technology behind it called a reflected structured light pattern, which means that a source of light would be reflected to an object, and the object, with grids and stripes, and the object will reflect this light back, which will be captured by a camera and will, through a triangulation and a complex algorithm, will give the 3D object image. What does that mean? That this technology is very, very sensitive to light and very sensitive to shiny surfaces or to saliva. There are other scanners. Well, those scanners are like the CEREC, old iTero, and so on. Another technology is the structure from motion, which is a technology not based on light source, but based on at least 2 cameras, which are capturing the object through 2D images. And these cameras are capturing these 2D images and superimposing points from the first image with the second image. That means, that pictures will be captured, and through triangulation and even more complex algorithms, the image of the 3D object will be given. So that means that this technology is not sensitive to light, but it's sensitive to the path, to the way, and to the pace of the scanning. So this is important. And those technologies are popular for the new iTero, for Prime Scan, for Medic, and so on. So what we need is an accurate scanner with the highest points and precision, and we have studies about that. Now, I just mentioned a 5-6 years old study, which is over the 12 regarding the trueness of 12 intraoral scanners. Now, meanwhile, we work on a new vast study which will be released very, very soon. So I can just mention what we have now published, where we did a comparison with by the mesh to mesh and nerves to nerves procedure, and we realized that we have, not going very deep into the study, that we have a group of 5 scanners of the 12, which give us enough accuracy,
Pues ese final de cuentas
trueness,
seguirle dando,
for
¿verdad?
full arch
Sí.
rehabilitation,
Por
meaning
eso le digo,
less than 40
que
microns
ya quería que se vinieran,
with
que
the
sea así de
mesh
poquito,
method and
para
less than
Sí.
25 microns with the nerves to nerves
Sí.
method. So we were using all these years one of this group to do the scanners. So those are things that we have to look into literature and see. And the other reason why the full arch scan is not accurate is that we take the scan body scan, the scan over the scan body, and what we do is go into the software and match it with the library file. Now the library file and the match is not congruent. And it's not a problem in a single tooth or a single implant case or even in short spans. But if we have this inaccuracy, added inaccuracy over the full arch, we have a misfit of the final result. And this is what this study shows in a quantitative and qualitative evaluation, that there is different levels of congruencies between the scan bodies and the library files. Another issue is that in the same system, the scan bodies are not congruent, are not the same. So added incongruencies over the arch give also a discrepancy, a distortion, right? The scan body depth in case of vertical scan bodies gives also inaccuracies in the depths for more than 3 millimeters. So it's also an issue. Also, the scanning strategy, which has to be respected, and that means we have to know the technology behind this and the knowledge about the technology, giving the assistant or the scanner, the operators, the feeling and the knowledge about what strategy is important and is necessary to be done in the scanning procedure in that specific scanner. So this is very important. And last but not least is the inter-scan body distance, which is an issue when we have long spans of soft tissue which the scanner cannot capture with high accuracy. Therefore, we did this article we wrote this article in 2020 as where we tried at the beginning to splint the scan bodies in a palatal side, and we encountered, of course, a higher accuracy of and a better passive fit of the work at the end, but it was still not perfect. Now, a recent article, that means that was in 2024 by the team of Frankfurt University, shows a systematic review, or does a systematic review over intraoral scanning procedure, emphasizing that it's not only the intraoral scan type, the scanning technique, the inter-implant distance, which is important, but the characteristics of the scan bodies, meaning the position, the design, the material, the shape, and the position in the arch. So that was an important conclusion. Therefore, as a sum, we have to choose from the market one of the systems which is appropriate to us to have a full arch accurate scan, able to give us an accurate passive fitted provisional or final. Going to the smart flags from Apollo, we can see that this is a scan body concept which has a horizontal flag, so it's a horizontal system which is aiming to overcome the jumping distance and has one flag or one wing or two wings in order to be able to fit on the arch accordingly. Has, as you can see, a specific geometry, also in a horizontal and also in a vertical way. That is actually a difference to many other horizontal scan body systems, because it has a complex geometry which is making the matching and the fitting to the library file much more easy and much more accurate, and has also a vertical component of the geometry, which is giving us a better orientation of the axis of the implant as other horizontal scan bodies. And also there are some geometries which are helping to the scanner to identify each and every horizontal scan body without mixing them up. So there are some characteristics which is, as the study said before, is very important for the matching, and it's increasing the accuracy in this horizontal scan body world. Additionally to that, it is a PEEK anti-reflective surface. It has a titanium interface, tight connection, and it can be used with 31 implant systems and with 13 scanners right now. A very nice article by Irena Zeiler, Vincent Famer, and Alessandro Pozzi makes a comparison between 5 horizontal scan bodies in vitro, then 4 intraoral scanners, 2 operators, and the outcome of the trueness by root mean square. The main results shows that the Apollo and the Nexus horizontal scan bodies have the best result, whereas Apollo has had the best accuracy. The best scanners are Prime Scan, whereas there are others which are also very good. The operator doesn't play such a big role as the iOS and the scan body effect. So as you can see here in the all horizontal, between all horizontal designs, the Nexus and the Apollo are the best, whereas the best is the one from the Apollo system. And that means, as a conclusion, that orientation alone, that means horizontal scan bodies alone, doesn't determine the highest accuracy, whereas the accuracy is implemented by the geometry, by the material, and by the scanner compatibility. So it's actually an ecosystem which are decisive for that. Now, going back to our case, we do a scan over these flags. As you can see, we position the flags in a way that the jumping distance is over jumped, where it's overlapped. And you can see that in the lower picture that when you have only 4 implants, for example, the position is more horizontal. Otherwise, you can also do vertical, but not as in the right side. That means we have to cover as good as possible the soft tissue parts, and they shouldn't touch each other, but should be in the neighborhood of each other, right? What is important for the scanning strategy is that we follow the scan strategy of the scanner, that the scanner tip doesn't touch the smart flex, that it is a balance rate of scanning. That means always the tip of the capturing camera should take 2 scan bodies at once in order to have always a following up and remember the technology of the overlapping the images. Then if the scanning is interrupted, which shouldn't be the case, or it's possible, but it's not recommendable, but then we have to start with a previous picture in order to have a nice stitching to that image, right? And look at the last picture that shows you also the surface horizontally, the geometry which has to be captured, and also the vertical component which gives us the right axis of the scan bodies. So now you have 2 options for the provisional or for the final. Doesn't matter, for both. You have an option 1, doing this in your own lab, which I do because I have my own lab and I need this provisional to be done on the same day. What do? I take the scan over the Apollo Smart Flex. I have from Apollo the components and the library files. I match my STL file with the library components, as I will show you in a minute, and I superimpose it with my wax-up, which I did at the very beginning. Yeah, I planned a smile, so I can actually provide a provisional in the same day. The second option which you have, you don't have your own lab, you can get back to the Apollo lab, which can become your own lab. That means that you scan with the smart flags, you upload the STL in the Apollo's portal, and what Apollo does is exactly what I do in my office, that he is matching the STL file with the library file, precising the implant position, doing also the smile design if you don't want to do it, and deliver to you either the STL file, which you can print, or the final work, which will take probably longer, so you have to give the patient in the meantime another provisional. So in fact, this is what is happening in exocad, either in your own lab or in the Apollo lab. The scan bodies will be matched with the library file by the best fit matching, one by one, and you can see how important is the horizontal geometry and the vertical geometry for the implant axis, and you see purple is always the best fit. Our case went the same. It's the upper jaw here, so you can see that we match the scan bodies, and we can definitely find the position of the implant. We have also the titanium bases for the screwing in the provisional and then the final. Yeah, this time is the final. Okay, so you can see the position of the implants, matched with the wax-up, which we did before, and designed accordingly or redesigned, because the soft tissue looks a little bit different. So this is the final rehabilitation, where we glued then the titanium base, and this is the final result of the patient with the soft tissue, and the patient is really happy with the final rehabilitation. So as you can see, is not a smart flag only, but is through the OpenCAD library, through the technical support with the components, through the quality of the system as a quality system compliance. There is an ecosystem or a workflow which is can offer you by the company a 48 hours full digital protocol, which is quite fast, even if you don't have your own lab. So another case which is similar, we have quite a lot of similar cases, capturing the digital data, planning in the same way, and going actually to the surgery, which is, I don't want to emphasize on that. We do always immediate placement, open if it's necessary, not open when it's not necessary, graft the gap, and so on. So it's actually always the same protocol, and we have this kind of result after the healing, right? We do then the scan over the smart flags. You can see always different geometries in order for the scanner to capture and not to mix up things. This is the surfaces which has to be scanned, so horizontal and also a couple of vertical. In the lower jaw, we kept 2 teeth also only for the provisional purposes. When I can take 2 teeth to support a provisional, I do that in order to protect my implants, especially when the bone offer is limited. So this is the scan of the lower. We scan after the provisional then, after the integration of the implants, once the provisional, and then over the implants. So we overlap the two, and then we start to create the work, the final work, which is matched in the same way. As you can see, the scan flags will be then, you see, matched precision, which is really kind of straightforward. We match it then with the design which we made at the very beginning, adapt it to the new soft tissue situation, and then we mill the final result. We mill the final mostly in zirconia, and we paint it with a fluid ceramic in order not to have any breakage and any compromises in the stability of the zirconia. So yeah, this is then immediately after insertion. Soft tissue will be a little bit nicer afterwards. So another case where, yeah, we use AI everywhere where AI is helping in the diagnostic or treatment. So this is a diagnostic tool based on AI where we can see what or we can document all our cases, but it's no doubt that that the teeth has to be extracted in the upper jaw. We start again with a smile design, so it's always the workflow. Maybe this is here also very useful for just to repeat the workflow. To see that it's always the same workflow, whereas the cases can be a little bit different from one case to the other depending on the surgical or anatomical and surgical details. So this is the walks up, which we do in this case. We create the virtual patient. That is the base for the walks up, and that is the base for the backward planning for the implants. You can see that we matched the same way, is always the same procedure. Here we had a registration of the movements which was not quite straightforward because the patient was long time edentulous. We had to correct that at the beginning and then went to the final rehabilitation. So here we have also some grafting planned, and we can definitely judge based on the 3D planning how much bone, if we can do an immediate placement, if we can graft at in the same session, how much volume do we need to replace, what technique of the grafting will be used, and so on. So digital planning is essential and is very useful to predict and to plan the implant surgery as detailed as possible, so you exactly know what you need to do in that session without a guesswork or without, you know, surprising effects. So we have also 2-3 teeth to support the guide. Always use and this is the point where the cases are different from one to each other, because we need to find a strategy where the guide would fit, where the guide is precise, we will maintaining the accuracy. As this is a different implant system, and you can see the 3 teeth to support the guide. We print the guide, and this is the situation after the surgery with an internal sinus elevation, and then the apple of flex for the final, and this is the final rehabilitation. Another case here, it was much more difficult because it was a limited amount of bone which we had to graft simultaneously, but the patient came after many all on 4, all on 6 and other proposals, but we managed to do the immediate placement and immediate loading in the same session with vertical implants. This is the immediate scan after the implant placement. Of course, not all implants will be loaded because it's not possible, but we had 6 implants to support. And the final can be done also, and this is something that the lab is also offering. The metal frame is if it's necessary. Of course, the metal frame is necessary mostly when we have an FP2, FP3 rehabilitation, but here the teeth were so short, and in order not to have a compromised zirconia, we preferred to do a metal frame. and this is how the patient goes home. Now, there is a nice article as a proof of concept case report done by Dr. Gerke and Dr. Vasiluk, lately also recent, and it shows that not only the zirconia fixed bridges, but also removable peak hybrid bridges and all kind of immediate loading protocols are very appropriate to be done with this ecosystem. Why? Because there is a smooth and very fast procedure offering the fast and a fast result and with a high accuracy at the same time, with few scans and few steps, and all the challenges are made easy. So in conclusions, based on all the literature which is existing in the horizontal scan body world, which seems to be the method to overcome the inaccuracies in the full arch scanning, we can say about the SmartFlex that that they have a geometry and optical capture which is improving the library matching, because it's a sophisticated complex geometry making possible the matching with a high precision horizontally and also vertically. Also the material, which is not reflective, is helping. Then the titanium interface has a stable connection, so again the accuracy with a multi-unit connection. The OpenCAD library, so we are not sending data and having a closed library system which we have to, so we don't have to outsource the work, so we can do the work ourselves. So this is a huge advantage, and of course reduce the need for scan body splinting. That means the horizontal feature is there, so there is actually a digital splinting of implants. So you can call it a digital splinting of implants, reducing the stitching, having that matching reliability by the geometry, improving the scan body recognition by the software. So that means we have in a short, again, the shortest time, few scans, less operator sensitivity, which is also very important, and a passive fit result. So actually the full arch digital success is not only scanner dependent. So we are not gonna push everything on the scanner or think that the scanner will solve all our issues. It is a geometry dependent. So actually we can say that the stability of the geometry or the reference geometry plus correct matching and accurate matching of the scan body with a library file is the ecosystem which gives you the predictable passive fit. So all these factors are actually very important. So that means that the SmartFlex are not doing the scanner more accurate, they are offering a scanning environment with all these puzzle pieces which is more stable. So that stability is what improves the accuracy and predictability in full arch rehabilitation and implant impressions. This is actually what I wanted to demonstrate. With this, I would like to invite you to the Digital Dentistry Society State of the Art or Consensus Conference in Antwerp, 16-17 October in 2026. The main topic is Digital Dentistry Unfold. We will have there a lot of workshops and new parameters for all the challenges which digital dentistry is asking for and is demanding. Apollo, as our partner in the Digital Dentistry Society, will be there, and therefore I hope that I will see everybody there. I thank you very much, Apollo and Dental Tribune, for this opportunity to share you in a nutshell the knowledge and the science and the clinics behind the smart flags of the system.
Our thanks to Dr. Lerner for sharing her expertise in advanced implant workflows.